Hi guys, welcome back. I'm Dr. Satyabama here for Raw Online, and today the topic is about the systemic complications with local anesthetic agents. You guys know when an anesthesia is got at a local level, prescribed, circumscribed area, then we're looking at the local anesthesia there. There can be local complications there and systemic complications by giving that particular injection, okay? Now, what are the local complications? Anything that happens in that particular area, for example, trismus, for example, needle breakage, all these are called local complications. We deal with them in a separate lecture. Today, the lecture about this is systemic complications. What are we going to get if I have an anesthetic given? Is there a systemic problem because of that? Okay. Obviously, yes. Okay. Because that's a medicine, that's a drug that you're going to be inducing. Okay, any drug that you give will have multiple effects, okay? There can be desired effects on it or can be an undesired effect on it. What are the desired effects? Are the local anesthesia that is going to be causing, which is what we require and which is why we administer the drug. So, the other undesired effects are, in general, okay, are going to be an overdose. I'm going to be giving injection, you're giving injection, and you didn't count the number of syringes that you have given or the cartridges that you've given, and you caused an overdose for the patient, okay? So then there is going to be a dose related problem. There can be a systemic distribution of the drug, an accumulation or a systemic manifestation of the drug of the overdose, or the extension of the pharmacological effects of the drug that I have given you. There can be a selective central nervous system or a cardiovascular system depression that can happen. Okay. Now, the maximum recommended dose, this MRD is what we normally talk about for local anesthetic solutions. That is as prescribed by the anesthetists of the American Society. Now, we do follow American regulations, a lot of it in our system. But slowly, with this COVID, I think our medical fraternity has really been pulled up, our public health has been pulled up, and we are making formulas and we are defining our our systems in place, which is pretty good. One of the benefits of the COVID is that we have our own protocols being manifested, which is pretty good. We never had them before. Okay, so the MRD for articaine, the maximum recommended dose for articaine is with the vasoconstrictor. If I am using, then that is 7 milligram per kilogram body weight. What is the vasoconstrictor that we normally use, which is adrenaline, isn't it? And the dosage varies for different preparations, starting from 1 in 80 to 1 in 1 lakh to 1 in 2 lakh thousands. Okay, so that's the vasoconstrictor that is added on. Now, in the other lecture of mine, wherein I was talking about the composition of local anesthetic, I did mention to you that when you are talking about any local anesthesia, two things that should come into your mind: the local anesthetic agent, the vasoconstrictor. These are the main components that are available on a vehicle, on a diluting liquid, on a vehicle that is there, followed by the thymol, which is the antifungal. Then you have a preservative, sodium metabisulfite, and reducing agent, that is the sodium metabisulfite. The preservative that we normally use is methylparaben here, okay? So, apart from the basic compositions that are there, now MRD is another thing that you should always remember of, okay? In India, when we say local anesthetic, it is predominantly lignocaine. So, lignocaine has taken a the other way of saying giving a local anesthetic agent, lidocaine, lignocaine, okay. Though it is the medium range of action, okay, though it is not a long acting one, it has a medium range of action. It is available with a vasoconstrictor and without a vasoconstrictor. With a vasoconstrictor, it is 6.6 is the maximum recommended dose. So, let's say 7. So, either be it articaine or lignocaine, the maximum recommended dose with a vasoconstrictor is 7 milligram per kilogram body weight. Whereas, with bupivacaine, it is 1.3 milligram per kilogram body weight, okay. So, remember the most common things that are being used, okay. So, the author's MRD as per Malamud is around, with articaine, is around 7 milligram per kilogram body weight, okay. Right. Now, let's move on. Now, what is the predisposition for the overdose? What are the conditions? What are all the criteria that you would consider when you're looking at an overdose of the patient. The age of the patient, and as it is based on milligram per kilogram body weight, then the weight of the patient matters a lot, okay? Then the sex of the patient, what are the medications that the patient is taking, what are the diseases that they have, what are the genetic predispositions that are there within the patient, what are the other problems or syndromes that the patient has, what's the psychological attitude of the patient. And the drug, those are the patient factors. Now, what are the drug factors? What is the vasoactivity of the drug? What's the concentration of the drug? And how much dose can I give? How am I going to administer this drug? Okay, what is the rate in which I should administer, and what is the vascularity at the site? What kind of vasoconstrictors I'm using? Now, the cause of overdose will depend on total dose is too large, okay, and the absorption is too rapid. As I mentioned the other time when I said when there was an abscess, we said when the acidity is more, the pH is more, then what happens is your drug does not get to the if there is a deficiency of the concentration of the ions that are penetrating, that are transfusing or diffusing through the membrane and entering into intracellularly. B, because of this abscess, the diffusion of the drug does not take place, and hence the depth of the local anesthetic is not there. But if you think that and you're going to increase the amount and you're going to give more dose, then you're going to cause an overdose problem. Or if the absorption is too rapid, or you have gone intravascularly, you did not aspirate. Remember, we talked about aspiration in 2 planes or 3 planes, especially Gauguet's 3 planes we aspirate to make sure that you're not very close to the maxillary artery. But then you are giving it into the vascular, intravascularly, then you have an overdose there. Okay. And how is the metabolism going to take place? Is it going to be very slow, or how is it hydrolyzed? What kind of metabolism is taking place? Like, for example, if you take the esters, they are hydrolyzed in the plasma and liver by the pseudocholinesterase into para-aminobenzoic acid, PABA, whereas the amides are transformed by the microsomal enzymes in the liver. And how are they eliminated? The elimination usually happens for prilocaine in the lungs. Most of it is given out, it is unchanged in the lungs. But whereas the esters and amides are eliminated in the through the kidneys, some of them in unchanged form. For example, lidocaine, about 10% of lidocaine is renal excretion, unchanged form. So, the maximum dose therefore will base on the age of the patient, the weight of the patient, the physical status of the patient, and the rapid absorption